This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 17, Pain Management. Introduction. Pain is probably the most common patient complaint encountered by EMS providers. Pain is an unpleasant sensation that disturbs a patient's comfort, thought, sleep, or normal daily activity. A patient presenting with pain and the manner by which the pain is dealt with widely vary. Pain may greatly affect the anxiety level of the patient and result in physical symptoms such as tachypnea or fast breathing, tachycardia, fast heart rate, or hypertension. EMS providers must have an understanding of the importance of pain management and its effect on overall condition of the patient. Pain management basics. It is vital for the EMS provider to understand when it is appropriate to administer analgesics. Analgesia should be based on reported pain. Suspicions regarding drug seeking should be based on evidence, reasonable evidence, possibility of pain. Match the dosage to the pain based on the protocol. So if your protocol, very simply, your protocol says if they're in pain, give this much pain medication, then follow your protocol. Use a pain scale. Verbal adults use a 1 to 10 reporting. No pain to the worst pain possible. So on a scale of 1 to 10, 10 being the worst pain you've ever felt in your entire life, what would you say this is today? Repeat frequently as analgesia is administered so that you can document that you've taken them from a 9 to a 4 in your transit. Nonverbal adults and children uses the FACES scale, which is on the next page. Asks the patient to point to the face matching their pain. Repeat frequently as well as analgesia is administered. And this is the face scale. So 0 here, there's no hurt. And then 5 hurts the worst. And have the patient point to the right one. A caregiver explains the scale even to an adult. Reading and comprehension should not be assumed on this. Pain management basics. Non-reversible analgesics should never be administered if they will confound later diagnosis. So the two things that we run into is head trauma and abdominal pain. We should be very leery to give any type of pain management at all. Interview patients to establish pain and sources. Children may not communicate pain very well, or what it actually is. They may just cry. Elderly patients may not acknowledge pain at all. Patients may fear being labeled as a drug seeker as well. Pain management drugs. Butorphanol, Fentanyl, Ketorolac, Meperidine, Morphine, Nubain, and Nitrous Oxide are the ones we're going to talk about. So first drug on our list is Butorphanol tartrate, which is Stadol, narcotic agonist analgesic of the kappa opiate receptor, and a partial agonist of the mu opiate receptor. Inhibits ascending pain pathways, which cause alteration in response to pain. Produces analgesia, respiratory depression, and sedation. Adult dose in this, intramuscular, 2 milligrams every 3 to 4 hours. IV, 1 milligram administered over 3 to 5 minutes. Every 3 to 4 hours. Geriatric, 1 milligram every 4 to 6 hours. Increase is needed. If we're given this nasally, 1 milligram, 1 spray in each nostril. Initially, as an additional doses may be given every 60 to 90 minutes later. This sequence may be repeated in 3 to 4 hours. Geriatric nasal, 1 milligram, 1 spray in each nostril initially, and an additional dose may be given 90 to 120 minutes later. This sequence may be repeated again in 3 to 4 hours. Pediatric, not approved for pre-hospital use. Contraindications, hypersensitivity to butorphanol. Do not administer to patients physically dependent on opiates because it may precipitate withdrawal because of its antagonistic properties. Pharmacokinetics, onset less than 10 minutes, duration 3 to 4 hours, and is excreted in the urine. One thing I should point out about the mechanism of action about Stadol is it's slightly antagonistic, which means that you only get pain relief from Stadol. Any other thing that you have in the system, it will block or become antagonistic of. Fentanyl, primary care drug. Generic on this is going to be fentanyl, and the trade name is going to be Sublimase. Mechanism of action. Stimulates central nervous system opiate receptors, producing systemic analgesia. On a milligram weight basis, fentanyl is 50 to 100 times more potent than morphine. Its duration of action is shorter than morphine or hydromorphone. An IV dose of 100 mics of fentanyl is roughly equivalent to an IV dose of about 10 milligrams of morphine. Fentanyl has less emetic effects than other narcotic analgesics. Adult dose 1 to 2 mics per kilogram, IV/IM, every 30 to 60 minutes as needed. Pediatric dose is 0.5 to 2 mics per kilogram per dose, IV, every 1 to 2 hours. Contraindications, hypersensitivity to fentanyl, toxin alter-mediated diarrhea, paralytic ileus, respiratory depression, and if they're already respiratory depression, how do you know that they're in pain? Acute severe bronchial asthma within 2 weeks of monoamine oxidase inhibitors, which is an antidepressant. Transdermal for management of post-op mild intermittent pain or opiate-naive patients. Non-opiate tolerating patients. So if they can't handle opiates well, might want to ask them if they've ever had opiates in the past and how they did with it before giving them something that's really, really synthetic, and fentanyl is synthetic. Pharmacokinetics, onset is immediate and the duration is 1 to 2 hours. This is excreted in the urine and feces. This is a primary care medication. Ketorolac, this is general knowledge. Ketorolac and Toradol inhibits synthesis of prostaglandins in the body tissues by at least 2 cyclooxygenase isoenzymes, cyclooxygenase 1 and cyclooxygenase 2. Now, we've heard about this earlier, that prostaglandin production causes inflammation, so by stopping cyclooxygenase 1 from converting to cyclooxygenase 2, what this does is causes an anti-inflammatory effect or decreases inflammation. So this is like an IV Motrin, anti-inflammatory, or NSAID. May inhibit chemotaxis and may alter lymphocyte activity, decrease pro-inflammation cytokine activity, and may inhibit neutrophil aggregation. These effects may contribute to its anti-inflammatory activity. Adult dose, 1 IM single dose, less than 65 years of age, is going to be 60 milligrams IM. Over 65 years, renal impairment or weight loss or less than 50 kilograms, 30 milligrams IM. IM multidoses, less than 65, 30 milligrams IM every 6 hours, do not exceed 120 milligrams a day. Not to exceed pretty much 60 milligrams a day. Less than 65, 30 milligrams IV. IV multiple doses, less than 65 years of age, 30 milligrams IV every 6 hours, and do not exceed 120 milligrams a day. Over 65, renal impairment or weight less than 50 kilograms, 15 milligrams IV every 6 hours, and do not exceed 60 milligrams a day. So there's some pretty stringent time frames on this, or actual dosage on this medication, Toradol. And it's anti-inflammatory. Contraindications, hypersensitivity to Ketorolac or other non-steroidal anti-inflammatory drugs, intolerance to alcohol. Pharmacokinetics, onset in 10 minutes, and duration is about 6 to 8 hours, and it's eliminated in the urine. Meperidine, primary care drug. This is Demerol, Meperidine or Demerol. Narcotic agonist analgesic of opiate receptors. It inhibits ascending pain pathways, which causes alteration in response to pain, producing analgesia or pain relief. It can cause respiratory depression and sedation of the patient. Adult dose 50 to 100 milligrams IM sub-Q PO or slow IV every 3 to 4 hours is needed for pain. Pediatric dose 1 to 2 milligrams per kilogram every 3 to 4 hours with a max dose of 100 milligrams. Contraindication, meperidine should not be given to patients with hypersensitivity to meperidine or its bispholates. Head injury, undiagnosed abdominal pain. Do not use Meperidine in patients receiving monoamine oxidase inhibitors. May cause patient to have a fatal reaction. Pharmacokinetics, rapid onset. Duration is 2 to 4 hours, and it is excreted in the urine. Morphine, morphine sulfate, or Duramorph. Mechanism of action, narcotic agonist analgesic of opioid receptors. It also inhibits pain descending pathways and adjusts the patient's response to pain. Can cause respiratory depression and sedation. Causes cough suppression by acting centrally on the medulla. Adult dose for pain is 4 to 15 milligrams, very slow, IV, IO, IM, or sub-Q, maximum of 15 milligrams. We also give this to patients in acute coronary syndromes and congestive heart failure. 2 to 4 milligrams slow IV over 1 to 5 minutes, every 5 to 15 minutes. Cap that at about 10. Pediatric dosage is 0.05 to 0.2 milligrams per kilogram, slow IV, IO, IM, or sub-Q. Contraindications: do not administer morphine to patients with hypersensitivity to the drug, hypotension, respiratory depression, or associated with pulmonary edema. Respiratory depression not associated with pulmonary edema. Head injury, undiagnosed abdominal pain. Do not administer to patients who are taking depressant drugs. Pharmacokinetics, onset 15 to 30 minutes, duration up to 7 hours, excreted in the urine and feces. Nubain, nalbuphine or Nubain, generic on this is nalbuphine, trade name is Nubain. Mechanism of action, narcotic agonist analgesic of kappa opioid receptors and partial antagonist of mu opioid receptors, inhibiting ascending pain pathways, which causes an alteration in the response to pain. Produces analgesia, respiratory depression, and sedation. Adult dose 10 milligrams every 3 to 6 hours is needed. Max total dose 20 milligrams. Maximum daily dose of 160 milligrams. Pediatric dose is not recommended for pre-hospital use. Contraindications: hypersensitivity to nalbuphine or bisphilics. Pharmacokinetics: onset 2 to 3 minutes. Duration is 3 to 6 hours. Excreted in the urine and feces. Nitrous oxide, general knowledge. Generic is going to be nitrous oxide, and the trade is going to be Nitronox. Mechanism of action: inhalation of a 50% mixture of nitrous oxide and oxygen produces CNS depression, as well as rapid pain relief. A nitrous oxide mixture produces rapid but reversible relief of pain. Adult dose 20 to 50% concentration mixed with oxygen, self-administered until the patient has decreased pain or pain relief is delivered. Pediatric dose is the same as an adult. Contraindications: the patient has a decreased level of consciousness. The patient has taken any depressant drug whatsoever. The patient has sustained thoracic trauma. The patient has respiratory compromise from any cause. Cyanosis develops during administration. The patient is unable to follow simple instructions. The patient has sustained abdominal distension or trauma, or the patient is pregnant. Pharmacokinetics: onset, peak, and duration is 2 to 5 minutes, and this is excreted by the lungs. Conclusion: the analgesics discussed in this chapter are very effective in alleviating pain. EMS providers must understand when it is appropriate to administer analgesics. Non-reversible analgesics should never be administered if they could confound later diagnosis. Examples of this would have been abdominal trauma and the head trauma. Protocols for pain management vary widely among EMS systems. EMS providers should be aware of their local protocols. Reference to this were taken from Beck Pharmacology for EMS Providers, Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.